These talks will be available to you through the AIM link, and if you connect with us at Angelus. What I forgot to do is to shout out everyone who is joining us. This Zoom and Microsoft Teams and everything has become such a part of our lexicon that we forget how amazing it is to bring people from all over the world. And as you can see, I'm not the most tech savvy person, but I wanted to shout out the people from all around the United States and multiple different countries who are coming in here. I remember when we did our first one of these in 2011 and people flew in. So we had to do it next to LAX. That was the thing. We needed to find a place next to LAX because people said, oh, we're going to get on a plane and come. How crazy is that now? And we had about 100 people and about 10, 20% of them had come from outside of the greater Southern California area. Now, thankfully, our issue is, well, should we even do it on site? Because it's such a global community. And that's phenomenal. But it's also great to bring friends in so that we can share time together and we can collaborate. And that's really what medicine is about. It's the proximity to your colleagues. It's about the proximity to the patients and the ability to discuss honestly what's going on and be happy and educate each other. So that's why I would always insist on, even if there were 2 people that showed up here, having something here. And why I'm proud and happy to have a very good friend. We're going on our 9-year anniversary of being friends and colleagues. This is Sapna Patel, who's just a meteoric rise. She's the chair of the SWOG Melanoma Committees. That data you just saw there comes from SWOG, comes from her leadership, and also works as the director of the Uveal Melanoma program in a very, very small place you might have heard about, MD Anderson Cancer Center. I hope that she'll enjoy her time here. She'll take something of what she's learned about Angelus and teach it to the MD Anderson people. But truly a pleasure to have you here.
Thank you, Omi. That was such a lovely introduction. I'm going to swing myself around so I can see the slides a little better. Oh, no, maybe I won't do that. Actually, MD Anderson just celebrated its 80th anniversary, and it looks and feels 80 in some parts. So we actually really could learn about what it looks like to modernize and improve the patient experience. Okay, I'm going to put a timer on me so I don't just ramble and ramble. So I'm going to talk to you guys about neoadjuvant therapy, which is medicine that you would take before surgery, and why this is a path that we're exploring in melanoma. So in full disclosure, I am the National Study Chair of SWOG S1801, which is currently the largest completed neoadjuvant trial in melanoma. So that's a disclosure that's relevant for this conversation. So the rationale for neoadjuvant systemic therapy, sometimes it's abbreviated as NAST, is that in the top cartoon, if you were to remove a tumor, there might be some microscopic tumor left behind. Let me see if I can point to it here. There's little tiny tumors left behind. That's microscopic cancer. The surgeon can't see it. They don't know that there was anything left behind. And then we infuse medicine, those Y-shaped drugs. That's essentially what immunotherapy is, or these antibodies. And what can happen is that immunotherapy is trying to get your body to create T cells against those microscopic cancers. And it can do a pretty good job. T cells here. As Dr. Carvajal noted, in the adjuvant or resected setting, it works for some people. Your body does generate T cells. But the idea behind leaving tumor in place and doing the medicine first is that you will get a larger expansion, a larger number, and a larger diversity of T cells if you leave the tumor in place, because now it's just not the microscopic, it's the whole cancer, the whole tumor, and your immune system will build up against it. You're still going to remove that cancer, but what's left behind is a much more more rich and diverse T cell population. So the idea is if somebody has resectable melanoma, you can take it out. Taking it out is still on the table, but perhaps doing immunotherapy first will give you a longer, richer response on the back end. And this was actually proven in a trial called the Opposin trial out of the Netherlands Cancer Institute, where they had a resected melanoma arm and then a neoadjuvant immunotherapy arm, and then patients went to surgery. And what you see in the bar graphs here is that in the adjuvant arm in red, compared to the blue bars, at first glance, the blue bars are taller. So that's number of T cell clones. You get more T cell clones if you do medicine first. And then in the light red and the light blue, and the first one's a little distracting because it's so tall, but if you look at the majority of the others, the light red bars portions are shorter than the light blue. That's the number of new clones that were present after surgery. So the surgery happens and how many new T cells did you develop? And so that's very interesting that leaving tumor in place gives you numerically more T cells on the back end and perhaps more clones, so a richer diversity. So they actually proved it. And what they proved as far as survival is that if you took neoadjuvant therapy, which is the curve in kind of gray there, that you had a better recurrence-free survival is the term we like to use in the adjuvant setting. You have a better recurrence-free survival compared to doing surgery and then possibly taking medicine after. This study was very, very small though, just a handful, few dozen patients. So there wasn't necessarily a difference in the long-term survival, which may be a good thing as a patient, right? It means whichever path is chosen, surgery first or medicine and then surgery, it's okay because in the long run, we can catch up your survival, whichever treatment you took. But we do like the diversity of T cells that come out with neoadjuvant therapy. So the Opposin trial was very what we call hypothesis generating. It was an early proof of principle, but it was a very small study. So you always need to validate these things in bigger studies. But internationally, what was decided is perhaps we need to have a consortium of doctors. So what they're doing in Australia, in Europe, and in the United States is harmonized. And we're not doing things 3 different ways and then trying to draw conclusions. So the International Neoadjuvant Melanoma Consortium was formed. And I feel like they might have stolen this picture from Dr. Sullivan, or maybe it's the inverse. So this is a graph of along the way when somebody's getting neoadjuvant therapy, what do you do with the tumor? When do you collect blood? And perhaps when do you also collect what we call microbiome, mouth swabs, stool samples, et cetera, and you collect them periodically along the way to learn things. It was important to harmonize this up front. Otherwise, you would have Europeans collecting at different time points and Australians and Americans. And we have seen global differences in treatments, and you often wonder if it's just due to a slight difference in practice. So the International Neoadjuvant Melanoma Consortium was formed and said, roughly, we're going to give about this much neoadjuvant therapy, somewhere around 2 months worth of neoadjuvant therapy, and then try to have surgery between the 2 and 3 month mark and then follow on. So through those guidelines, the International Neoadjuvant Melanoma Consortium went and pooled a bunch of data out of the United States. The first trial was run at MD Anderson using targeted therapy. I can't see that one. That was out of Australia, the next one out of Netherlands, another MD Anderson using immunotherapy, the University of Pennsylvania study using 1 dose of immunotherapy, just a single cycle of pembrolizumab, and then a study using just immunotherapy with no adjuvant therapy. And you can see already there's a variety. The yellow bar is how much neoadjuvant therapy. Everybody got a different amount of weeks of neoadjuvant therapy, but roughly in that 2 to 3 month mark. But everybody got a different variety of adjuvant therapy, some up to a full year, some half a year, some a few. So all of this needed to be harmonized. But importantly, when you pool this data, and pooling will have some flaws because the patients who enrolled are different, characteristics are different. So we take all of this data with a big grain of salt. But when you pool the data, you find that the immunotherapy patients end up having a stronger survival based across many different trials than perhaps the targeted therapy. So if there's a BRAF positive melanoma, as Dr. Carvajal said, you have options. You have options between BRAF pills or immunotherapy infusions. But even in this setting, it looks like, apologies, everybody's getting that alert. Even in this setting, it looks like immunotherapy may run the day here. And so higher survival curves with the immunotherapy and targeted therapy. And what we see is, again, with neoadjuvant therapy, you can get single agent immunotherapy, or you can take that immunotherapy in combination with more side effects, running the risk of missing your surgery date because you're dealing with side effects. So with all of that consideration, it does still look like more immunotherapy upfront might be better, but very small data sets here that we have to validate essentially. This curve overlaps what if you just went to surgery first? If you went to surgery and took your adjuvant PD-1 single agent, it's interesting how that overlaps with the neoadjuvant PD-1 curve. So that's a very interesting observation. And it proves the point again that we have not compared adjuvant head-to-head with neoadjuvant. We have the very small Opposon study that, put this seed in our head, was proof of principle, but we've not actually proven that neoadjuvant is better. And so there are two, what I would call milestone or landmark trials that will help answer this question. And as I disclosed, S1801 is really one of them. This is a study of up to 500 patients, but actually we stopped at about 350, 360 because we had enough events occurring that randomized patients 1-to-1 to either traditional surgery and 18 doses or a year of pembrolizumab every 3 weeks, or 3 of those pembrolizumab doses, then surgery sometime between months 2 and 3, and then 15 doses of pembrolizumab after. So there's balance in both arms between the number of pembrolizumab doses. There should be balance between the surgery, both arms getting surgery. It's just a question of, does surgery upfront actually do anything to improve your outcomes? And so the outcome of this study is what we call event-free survival. How long does a patient live on each arm until something happens? And that something is defined as their disease recurring or progressing. So if you're on the neoadjuvant arm and your cancer actually gets bigger on treatment, because we know immunotherapy does not shrink 100% of tumors, did your tumor grow in a way that it's no longer operable, that you actually lost your operable window? That would be important to know how many times that happens when you give pembrolizumab before surgery. What about patients who do surgery, but because they go to surgery first and it ends up being a big, bulky surgery with lymph nodes and so forth, they have problems with wound healing and they need wound vacuums or other things. They never actually get started on the adjuvant therapy. That would be considered an event, and it might give us thinking to use neoadjuvant therapy if the tumors shrink and the surgeries can be minimized so that there isn't this postoperative waiting period for healing. Anytime after recurrence, say both arms go to surgery successfully, finish their year, any melanoma recurrence after that is an event. And then because this is the S in event-free survival and progression-free survival and overall survival accounts for being alive or not, then death is another endpoint. And it's death from any cause, which I have, issues with. It should be melanoma specific. But this study actually closed to enrollment about a week ago, and we're very happy to announce that. That means that we didn't need to take 500 patients and randomize them because we're getting the answer sooner. But I have no information on what that answer is going to be. We haven't combed through the data. We hope to have information later this year. And one of the things we learned in 1801 is you actually have to gross the specimen properly. When you do a neoadjuvant pathologic response, it's a little bit different than just opening a tissue and saying, is there cancer or not? That's a lot of times the only question we're asking on a biopsy or a surgical specimen. Is there cancer and kind of how much? But on a neoadjuvant, you actually need to get the entire tumor bed and ask the question, how much is dead tumor and how much is alive? So it's not simply is there melanoma and measure how much, it's how much on a denominator of how much was there. And that requires grossing tissue very specifically. If you have, these are lymph nodes, they're black because they have melanoma involved. If you have a lymph node less than 5 centimeters, it requires grossing a tumor in a very specific way versus if you have it greater than 5 centimeters. Usually less than 5 centimeters, we gross every few millimeters. And then if it's greater than 5 centimeters, because that would make hundreds of slides for us, we end up grossing at 1 centimeter hashes. So we learned this as we were developing 1801, that we would get tumor blocks and it would give us the tumor size, and we would realize, well, it was a less than 5 centimeter, but we actually didn't get enough slides here. It should have been grossed more cleanly so we can actually say how the tumor responded. Similarly, here's one that was small. It doesn't look like we got enough tissue. So it was very iterative, this process, where we went back and taught sites, here's some information to post in your surgical suite and in your pathology suite. Make sure the tissue is grossed in a specific way so the pathologist can do a neoadjuvant read. That's very important. It's not just a regular pathology read. So we just have some guidelines here that I think were helpful for sites. The other landmark trial is the Nadina Trial. This trial is being run out of the Netherlands and involving, I think, most of the Netherlands, maybe also some parts of Europe. And what this study is doing very similarly is saying you'll get some neoadjuvant immunotherapy, a therapeutic lymph node dissection, because these are mostly for patients with lymph node involvement, or you'll get a therapeutic lymph node dissection and then your adjuvant immunotherapy. Interestingly, they have a few extra variables in this trial. So after the therapeutic lymph node dissection, the tissue is grossed properly, and it looks like the majority of the tumor is either dead or gone, or all of it is gone. Major pathologic response, pathologic complete response, or near pathologic complete response. Then they could actually not do any adjuvant therapy. So they could stop right there and be done. If they have no major pathologic response, so more than 50% of the tumor is still alive and kicking, and they have a BRAF mutation, it can be BRAF adjuvant therapy or immunotherapy. So that's a variable in there. And then if they don't have a BRAF expression, then they would just do immunotherapy. Very interesting design. This study will probably be finished in 2023. So we'll hear results maybe next year or the following. And one of the things the Netherlands did that was very interesting across many of their opposite trials was they looked at something called an interferon gamma signature. So when a melanoma diagnosis is made, you guys know there's a biopsy that's taken. In that biopsy, you can run a series of genes for a cytokine or a signaler in the body called interferon. And based on that interferon signal and potentially tumor mutational burden, but in data that I can't share right now, it looks like interferon gamma signature may be sufficient. It looks like there are people, the curves essentially separate, and you can say there will be responders to the neoadjuvant therapy, and there'll be less favorable responders. They're still responding, maybe just less favorable. So on the basis of that data, the Netherlands group, that's a very prolific neoadjuvant group, they've developed the Donomy study. And the Donomy study says, we'll take that pre-treatment biopsy, and in 2 days, we're going to tell you if you have an interferon high or low signature. I feel like we could never work that fast here in the United States. In 2 days, the tissue has like barely moved out of the warehouse. But in 2 days, they're going to know if you're interferon high or low. And based on that, you're going to get randomized. So if you have an interferon high signature, you're going to get single agent. You're going to get single agent PD-1 because that's what some of their preliminary data suggests. You might get it in combination with this dometinostat. Dometinostat is an HDAC inhibitor. And if you're interferon low, you're going to get dometinostat with that Nivo, or you're going to get what you should be getting is combination Ipi, Nivo, dometinostat. And then everybody goes on to have a therapeutic lymph node dissection, et cetera, et cetera. It doesn't look like they're doing adjuvant therapy here. So that's very interesting. They're using that pre-treatment interferon gamma signature. And then across multiple trials, what they found is that if you have an interferon gamma high signature, it looks like you might do well with Nivo and Nivo Ipi. But if you're going to do well with Nivo, you may spare yourself the toxicity of the Nevo-Ipi and just take single agent. In the interferon low, interestingly, it looks like double is giving you some responses, but they're still suboptimal. So in low patients, we're brainstorming, should that be triple therapy or something else? And then one of the last slides I have is about changing surgery in response to your neoadjuvant therapy. So what they're doing in the Prado study in the Netherlands is giving patients neoadjuvant combination for 2 cycles. Then they'll take the index lymph node and under the microscope determine, did you have a near response, a partial response, or no response? If you have a near response, you don't have to go through with that therapeutic lymph node dissection, and you'll just be monitored. If you had a partial or no response, then they will do a therapeutic lymph node dissection and followed by adjuvant therapy, depending. So that's an interesting strategy in neoadjuvant to basically personalize the response. So neoadjuvant therapy is really intriguing. In small studies across many countries, there's been a signal, but we really need a head-to-head trial against adjuvant therapy. We need to demonstrate that neoadjuvant therapy is actually better than what we've been doing. And S1801 and Nadina will be the 2 kind of milestones. Once those finish and report, we'll have a couple of studies now to discuss. And there are opportunities to improve the extent of surgery with the Prado study, perhaps the choice of neoadjuvant therapy with the Nadina based on an interferon. The choice of adjuvant therapy based on Nadina, which was BRAF or targeted therapy, and the choice of neoadjuvant based on the Donomy for interferon signature. Pathologic evaluation of the surgical specimen we think is a really important step, and it's not the same as pathologic evaluation just after surgery alone. So this requires special attention. And 1801 and Nadina are going to be co-analyzed together to look for that interferon gamma signature so we can actually see, is it helpful in 2 different studies using similar models. And that's it. Thank you, guys.